Good morning, students. Here we are once again. Today, chapter 34, suicide and suicidal behavior. Okay? So first of all, let's look at some terms. What is suicide? Suicide is self-directed violence, violence towards oneself. And the individual is deliberately trying to kill themselves. And there's no other way to put it. It's unfortunate, but this is where it's at. Suicidal ideation is thoughts of wanting to hurt yourself, kill yourself, and suicidal intent is at the time of injury or death, the individual had thoughts of killing themselves. A suicidal plan is basically an organized method with a time frame, and that person is considering killing themselves. It is believed that most people that attempt suicide would consider other factors, so they would they are ambivalent and would consider other means of resolving the problem. If they had a way out, they would consider it. That's what it's actually saying, that those who consider suicide are ambivalent about it, and if you placed another reasonable solution, that they would consider doing that instead of committing suicide. Prevalence and incidence of suicide. 1 million people per year globally die by suicide. Okay, 10 to 20 million engage in suicide, and in the United States, as of 2006, 34,000 people die of suicide. According to the CDC, suicide is the 11th leading cause of death, which is third cause of death among 15 to 24-year-olds. So in that area, in that category, it's third. Risk for suicide, contributing factors. Well, familial history. If there's a history of suicide within the family, father, grandfather, mother, brother, etc., then you are 2 to 8 times at greater risk. Individuals or patients with physical or sexual abuse, greater risk. If you've lost a job and your status, if you've lost a loved one, PTSD, etc., financial problems, you're at greater risk. If you have impulse and aggressive personality traits, that's also a contributor. So patients with bipolar disorder are at greater risk, because bipolar disorder is, if we remember back, they can be very impulsive, patients with bipolar disorder. And borderlines, remember we talked about borderline disorders. These patients can also be at greater risk. Okay. More than 90% of people who die by suicide have some form of psychiatric illness. Okay, so of the 90% who die by suicide, 90% of them have a psychiatric illness and or substance abuse. So who do we see dying of suicide? Psychiatric patients and substance abusers, and or psychiatric patients with substance abusers. Okay, that's not to say that all psychiatric patients die by suicide. Okay, now 95% of the people with psychiatric disorders do not die by suicide, 95%. So you're saying only 5% of the people with psychiatric disorders die from suicide. But out of out of the out of the 100% that do die from suicide, 90% of them have a psychiatric disorder. Okay, 2/3 of the people who die by suicide are depressed at the time of death. Okay. All right. Here's a mnemonic that'll help us with suicide. Is path warm? Slide 9. I for ideation. Do they have thoughts of doing it? Have they communicated these thoughts? Have they threatened to do it? S for substance abuse. Do they use too much? Have the substance abuse increased? P, purposelessness. Do they feel they have no reason for living? Okay. A, for anxiety. Is there an anxiety issue, agitation? Are they insomnia? They're not sleeping. T, for trapped. Do they feel there's no way out? This is the only way to resolve the problem. And remember that there's that ambivalence where if they had a way out, they would take the way out other than suicide. H for hopelessness. Is there no hope? Nothing to look forward to. Withdrawal. Does a person find themselves withdrawn? Is there A for anger, uncontrolled rage, or etc.? Restlessness and risky behaviors. Is there mood changes, severe or dramatic? And psychological factors related to suicidal risk. Psychiatric illness, we mentioned substance abuse, psychic ache, that's when your head just really hurts. I've never had that, but there's just like your head is going to explode, mind really. And then feelings of hopelessness. Physical or other factors related to suicide. There could be physical factors that, like for example, a chronic physical illness, neurologic disease, like chronic physical illness would be COPD, chronic cardiovascular problems, HIV, AIDS, kidney failure. Patients with kidney failure, the fact that they have to go 3 times a week and through dialysis, they can't take it, and eventually some of them wind up killing themselves. Pain disorders, they can't take the pain anymore, and they just decide they're going to end it all. And we already talked about environmental factors: divorce, stressful events, loss of a job, loss of a loved one, loss of a child. Protective factors preventing suicide: religious or cultural beliefs that discourage suicide. If you have a good support system, good family support, religious support, cultural support, that can prevent it. Effective clinical care and physical care and care of that substance abuse disorder, you can prevent it. Easy access to various clinical interventions, support groups, all kinds of suicide prevention hotlines if you have access to that, etc. And then, of course, we already mentioned friends and family that support you, and also good coping skills. You want to foster better coping skills to deal with stress. Also, some factors would be the fact that that person is restricted from access to guns, knives, pills, whatever is needed for them to commit suicide. Support, we already talked about healthcare support, familial support, community support, and skills problem, conflict resolution, and nonviolent handling of disputes. Nursing assessment for suicidal risk. consider, first of all, you need to form that therapeutic relationship with that patient. Focus on establishing that alliance so that you can build trust with that person. If that person's feeling a certain way, they will then be able to communicate that with you, okay? If they want to commit suicide, or they have a plan. Uh, and definitely being compassionate, being considerate of that patient, and understanding that these individuals are unique. You don't know how they feel. You have an idea. Maybe you've been through something like that, but you can also express that. Attempt to understand the experience that the suicidal person is having, but you can't say, "I know what you're feeling." You could say, I, I'm really trying to understand how you're feeling. I've felt something like that in the past myself, etc. Uh, okay, and these are some questions that you could ask for suicidal assessment. Have you ever had thoughts of harming or killing yourself? Just, you know, harming is kind of like downplayed. Killing is the thing. We're worried about suicide. Harming yourself is one thing. Killing yourself is another thing. When was that? What were you thinking, feeling at the time? Did you ever act on your thoughts of harming or killing yourself? Tell me about those times. These are questions that we can ask. Are you thinking about killing yourself right now? Are you feeling so bad that you have thought of taking your own life? Have you ever been so bad that you feel you can't go on? What have you thought about doing? Have you thought about specific time or place? And do you have access to a firearm, a knife, pills, etc.? Okay, so this is some really straightforward ways of dealing with people with suicide. You don't want to dance around the issue. You want to directly ask the person, do you want to hurt yourself? Do you want to commit suicide? Do you want, not hurt yourself, do you want to commit suicide? Do you want to kill yourself? All right. The less lethal attempts by method, okay? Less lethal is overdose on non-prescription pills or drugs, except for acetaminophen and aspirin, which can be kind of lethal, okay? The most lethal method is firearms. Second is hanging, and then overdose on antidepressants. Barbiturates and sleeping pills are pretty big, and aspirin and Tylenol rank third there with it. Jumping, wrist slashing, carbon monoxide poison is less lethal but can prove lethal. Possible outcomes for clients related to suicide: suicide self-restraint, okay, that they restrain themselves, they're able to communicate with you because they trust you. Social interaction skills, they're able to interact with people and let them know what's going on. Depression, self-control, distorted thought, self-control, and will to live. Immediate interventions for clients contemplating suicide: removing, of course, the means of suicide to reduce the risk of it happening. And if hospitalized, then what you want to do is that patient will be on one-to-one watch, and until the doctor deems, or the nurse practitioner deems, that they don't need it anymore. But you put that person on one-to-one, and that individual's always at arm's length to that patient, okay? They are always at arm's length. Even if they go to the bathroom, they're going to be at arm's length with that patient. You don't leave them alone, and you make sure that there are no sharps, no pills, nothing in the room that person can harm themselves on. Even a comb, they're watched as they use whatever combs, even plastic utensils. You don't leave them laying around. If they're in a community setting, then the family is brought in to help, and they remove any means that these people might harm themselves with, and you provide immediate support. helping loved ones cope with suicide offers support and guidance to the survivors. The person has already moved on. Explained that the emotions usually do subside with time, but there is no set time frame for the process. Let supervisors know that painful feelings may reoccur. Suggest that they seek professional mental health counseling for a time after the suicide. And again, when we're dealing with patients in hospital with suicidal ideation, um, we will take extra care to make sure that these people do not harm themselves. Okay? Thank you very much.